Hello, welcome to this short summary of the European Resuscitation Council's 2015 guidelines. I'm Jerry Nolan, I'm a consultant in anaesthesia and intensive care medicine at the Royal United Hospital in Bath in the United Kingdom, and I'm lead for the post-resuscitation care guidelines. I'm going to focus on 5 main points. Firstly, urgent coronary catheterization following out of hospital cardiac arrest. Titration of inspired oxygen concentration after return of spontaneous circulation, targeted temperature management, prognostication of outcome in the comatose post-cardiac arrest patient, and regionalization of cardiac arrest care. It's now widely accepted that patients who have ST elevation on their ECG after being resuscitated from out-of-hospital cardiac arrest should be taken for urgent coronary catheterization and percutaneous intervention, or PCI, if indicated. It's estimated that about 80% of these patients will have an acute coronary lesion amenable to PCI. The patient's conscious level should not be used to determine their eligibility for urgent catheterization, or to be absolutely clear, that the patient is comatose is not a reason to deny immediate catheterization. Several observational studies have shown that in the post-cardiac arrest patient, the 12-lead ECG is not very reliable for predicting the presence of an acute coronary lesion. Post-cardiac arrest patients with a likely cardiac cause of their arrest, but who do not have ST elevation on their ECG, should be discussed with a cardiologist so they may be considered for urgent coronary catheterization. There's currently no consensus on this approach, and it's the subject of ongoing research. We know that low blood oxygen values or hypoxemia are harmful and must be avoided in the post-cardiac arrest patient. However, there are several animal studies that indicate that high blood oxygen concentrations or hyperoxemia early after return of spontaneous circulation may be harmful to cells, particularly neurons that are recovering from severe hypoxic ischemic insult, such as that caused by cardiac arrest. The data from human observational studies are conflicting, but there is now good evidence that after acute myocardial infarction, too much oxygen can actually increase the size of an infarct. Until more data are available, we recommend that once a reliable arterial blood oxygen saturation can be measured, and that can either be done by pulse oximeter or arterial blood gas analysis, the inspired oxygen concentration should be titrated to achieve an oxygen saturation in the range of 94 to 98%. Hypothermia is associated with worse neurological injury after cardiac arrest, and we know it's common in the first 48 to 72 hours, and it must absolutely be avoided. This requires active temperature control, and the preferred term for this now is targeted temperature management. A recent study, the TTM trial, showed no difference in neurological outcome when a target temperature of 36 degrees was compared with 33 degrees in post-arrest patients. For this reason, current international guidelines recommend that these patients are controlled at a constant temperature, somewhere between 32 and 36 degrees, for at least 24 hours. The previously recommended target range was 32 to 34 degrees centigrade, but following the recent TTM trial, many intensivists have elected to use 36 degrees centigrade as their target temperature. Identifying the comatose post-cardiac arrest patient who will ultimately make a good neurological recovery is challenging. In the past, prognostic tests were applied too early, and reliance was often placed on just one type of test or modality. In many cases, this resulted in inappropriately early withdrawal of life-sustaining treatments. The new guidelines recommend that prognostication is generally delayed until at least 72 hours after return of spontaneous circulation, and that multiple modes are used. These include clinical examination, electrophysiology, biomarkers, and imaging. A prognostication algorithm summarizes these steps, but should be applied in practice only by highly experienced clinicians. The need for 24/7 access to cardiac catheterization laboratory has driven increasingly regionalization of post-cardiac arrest care patients. These so-called cardiac arrest centres, or in some places heart attack centres, will increasingly take a greater proportion of out-of-hospital cardiac arrest patients. Some observational studies have documented better outcomes from this regionalisation of post-cardiac arrest care, but this requires ongoing research. So in summary, the main changes in post-cardiac arrest care in the 2015 guidelines are firstly to consider urgent coronary catheterization and percutaneous coronary intervention following out of hospital cardiac arrest of likely cardiac cause. Once arterial oxygen saturation can be measured reliably, adjust the inspired oxygen concentration to achieve an oxygen saturation of 94 to 98%. Targeted temperature management is used to prevent hyperthermia. Prognostication of outcome is delayed for at least 72 hours and should be multimodal. And finally, post-cardiac arrest care is being increasingly regionalised.